now?
Yes.
Yeah. Okay. So this is an occult fracture of the greater tuberosity. Yeah.
Yeah. That's that's like um do you know the mechanism of that? Was that a lot of compression involved in it, or
Direct trauma. I think it was a hand catching themselves as they go up,
wow.
and they just banged, just direct, probably a trauma directly from the acromion, I think, and it's just enough.
Is that sharp shard
Yeah,
simply a tilted cortical piece?
that would be my best guess.
Wow.
It just lifted up
Yeah.
in amongst things, just flaked off, probably with traction, probably from traction of the supraspinatus at the moment of impact, or something like that would be my best guess.
Meaning that you believe there was some evulsive type response to and are we
I think with that sort of trauma, I think you're always just
yeah.
guessing.
Yeah.
People typically it's tumbling down the stairs. Did they hold the traction? Uh, did the acromion just meet the?
Yes.
So this is again this is a complicated scan if I remember rightly. So you've got lots and lots of synovitis around the tibialis posterior tending to come through, and then I'll probably have to pull this through. So you've got uh, quite a lot of vascularity, and then but also synovitis here. Yeah, it's going a bit too fast, so I'm going to stop that and pull it through, so we can go a little bit more slowly. So the tibialis posterior hypervascularity there,
Yes.
just looking as you come around the corner. Not this is enlarged, but not very much. Uh, so this is which is why I'm thinking of an inflammatory story. And then we come here, and I'm afraid it's just I've there was quite a lot. This I think is around the peroneal tendons.
Yeah, I see the CFL down there, I
Peroneal.
think.
There's synovitis dripping over the edge of the thing. I was very convinced when I first saw this that I was going to see some sort of subluxation of the peroneal tendons at this point, but I couldn't get them, though they moved around in the sheath. So there was obviously some sort of injury. I couldn't get them to jump over onto there. But there's synovitis under this is the CFL ligament,
Yeah.
and there's synovitis here under the joint. This all has a very inflammatory look to me. So, so they will have gone off to be reviewed by rheumatology.
Back a little further, did I see the ATFL or was that the CFL? Because I thought I saw the ATFL right about.
That's still the CFL. These are
Yes.
still the perineals sitting on top of it. Now there was a lot of nonsense just before then. So
Right
here,
there.
yeah, that's probably ATFL there. I suspect so. I think I
Yeah.
was. This is one of those late night editing jobs. Yeah, where
Because
you just got
I'm going, how did he get there and then back to there?
I know. It was, sometimes I try to keep up with it, do everything a day or two after while I still remember the cases.
Yes.
And sometimes there is just so much, there's just too much to.
John, talk me through your Doppler prep again, because you always do. And again, I think I'm looking at it and I'm seeing GE quality here. But your standard Doppler setup. Can you talk me through that? Hello, you.
Hello. Hello. Oh,
I like your headdress. You look like something from biblical times.
Yes. Right. This is where this, okay. You can't stay around. Yes, it's all right. Florence gets a little bit stressed at night, so
Understand.
yeah.
The box
So
is
yes,
the Doppler box. When you put that on, are you already completely set up to your refinement? In other words, is it preset, or what do you do?
it should be, but I'm using lots of machines that other people use, and I don't really. I like to adjust things when I do these things, so I don't like to. So I don't necessarily have one fixed way of doing it. I like the box coming from the top of the screen, so I like it to touch the top of the screen and come down. I don't like it to fill the whole screen because it slows the picture down. So I have, but you want enough so that you don't miss a bit, because often you get inflammation where you're looking for it, but sometimes it's sitting away in a corner and there's some inflammation in the soft tissues or something like that you're really better off picking up because inflammatory problems in particular, they can have they can be sort of non-stand, that they don't always obey the rules. The inflammation is not always in the joints. Sometimes it's in the subcutaneous tissues, and that's one of the reasons for having it all the way up to the top. But it's also because you get artifacts, and sometimes if you've got something very superficial that's vascular, it will repeat down through your picture. But if you can't,
Oh.
but it will do that even if it's not in your box.
Oh, so you're basically just seeing what could be throwing multiples down into your picture.
Yes,
And
yes,
and so when we talk about clinical practice here, are you lightening up your touch at all, or
yes.
do you scan always as though you're Dopplering?
No, not at all. I use a lot of pressure a lot of the time when I'm scanning. But I often use very little, but equally, I press very hard. If I'm doing a plantar fascia, I have my, when I scan a plantar fascia, my arm is right by my side, and I grip the probe, and I would a screwdriver, and I don't press with my arm at all. I just have my arm by my side, and I
You
lean
just
my body
lean.
in.
Okay.
Yeah, and you just lean in because you sometimes that's what you need to get your picture.
Yeah, 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 yeah.
And the same sometimes with Morton's neuromas. When I'm scanning from the plantar surface, I will my hand is by my side, my elbow is by my side, and I use my body weight just to press in, and with my other hand just pulling back on above the metatarsals just to make space. And sometimes on a big foot, that's what you need to get the picture.
And so you
And
then lighten up a bit. Are you adjusting gain as you go? Do you take it up to
yes.
where it totally obliterates the screen and then you back it off?
I don't, in principle, yes, you don't have to do that 90% of the time. When I'm really looking for something that where there's not a lot there, then yes, I'll be using those sorts of techniques. But most of all, I haven't got it on this, but you have something called scale or pulse repetition frequency, and I tend to set that quite low, lower than the manufacturer's volunteer. So usually they set it about 6 or 8 centimeters a second.
When you say low, are you talking about to detect slow flow?
Yes, small quantities of slow flow. So I'm detecting slow flow in structures that have very subtle vascularity, uh, or more often because when you're looking for vascularity, there's usually plenty. When you see it, there's usually plenty of it. What you're doing is when you want to be able to say with some degree of confidence that there is no vascularity, that tends to be when you max everything out. Because in general, when there's stuff to see, you can see it without too much trouble. It's the difference is that when you want to say that there isn't any there, you then have to go the extra yard, and that's when you're using very subtle techniques.
Very slow flow, very light touch. And how long will you hold the view to be
Not very long. No,
3 to 5 seconds?
They say that sort of thing, that when it's there,
When the
if
spirit moves you.
yeah, well, you have a look. I don't measure it. Some of the scientists come back and say, well, you have to wait for the flow to come. I say, well, if that's the case, why do I see it when I'm scanning through?
Yes.
So on your modern kit, it doesn't take very long, and if you're going to see the flow, what's important is that you're not pressing. Because I often find my students will often scan things and say there's no flow in it, and I will go and I look at it, and there is flow, because we see a lot of very small vascular lesions, superficial vascular lesions, uh, in our radiology work, and my students are always coming back saying, I think it's probably a cyst. There's no flow in it, and I put the probe on and play with the settings and don't press very hard, and it's like, no, guys, there is definitely blood flow in this.
Well, let me ask you this. What are the additional um, uh, tweaks that you do to this image? Will you go up and down, or will you fan the slice? What are you refining it? You're just refining the black and white and letting Doppler do what it will?
To a larger extent, it's when you're looking for Doppler, then you not really care what the grayscale picture looks like. So
Okay.
you just so all the anisotropy goes pretty much out the window.
Okay.
Insofar as you might, if you're trying to capture a loop or a picture to show someone, that's different. When you're actually looking for it, then you're not interested in the grayscale at all, and you're just running the probe over, and the direction matters a little bit, but for low flow issues in musculoskeletal, you're not looking at linear. A lot of the people, when they're teaching Doppler, they're teaching it from a vascular point of view, where you're looking at vessels that are passing essentially horizontal to your picture. And so a lot of their mantra is based on that. So you're always trying to optimize the angle for the Doppler. That's not the case with with what we're looking at. You always have a good Doppler angle on these multi-directional structures, because they're not going in, when you're looking at neovascularity, when you're looking at microvascularity within these structures, it is not linear. It's not stretched out. This isn't carrying blood from A to B. This is carrying blood through like a tree. So in any one vessel, there will be a point in it that will light up nicely, because it'll be going in the right direction if you have your settings set appropriately. So it's more about having your settings there, your touch, and giving it enough time to show. So you're not just pulling it across and just with blur of artifact. So you've got to move slowly enough that the artifact disappears or almost disappears. So
That
when you see my pictures, there will usually be a little bit of artifact on, because I like to have it set up so that there is some artifact in the process. Otherwise, I'm not really sure that I've got sensitivity there.
that's fabulous. That's good stuff, John. Now I'll be quiet.
Right. So let me have a look. So I think we've done this one. I can't remember. I think we came back because we were talking about Doppler. Let's go back to the list. Yeah, it's maybe a couple of weeks ago, so I'll have to remember what came back. When is this going to show? Yeah, there we go. Shout if you've seen it before, but I don't think I've showed you this one before.
No, I don't think I have.
Do you see what's going on there? Is it going through? I know
Yeah,
going to the plates is a long way.
yeah, we're distal wrist. I mean, not distal wrist,
Yeah,
but we're.
distal elbow. Where
Oh,
the and that is this is the distal biceps tendon
really? It
up at
looks
the
like the
top here.
it has the appearance of the long head of the biceps with the fluid around it, right
It
about
is
there.
it is the long head of the biceps. You're right.
Oh,
A long and short head. But
yes, yes.
you're in
What
in the other
about
domain.
that? Now,
And it's got an
what am
effusion round it there.
what am I
So this is
seeing on the cortical area to the bottom right? Is there something? that's amiss with the joint itself.
No,
Okay.
no. That's the nature of the slice we're taking.
Okay.
It's you've got a fluid collection here around
Yes.
the biceps.
Yes.
However, if you look at the biceps itself, there's a ganglion inside it.
Oh my goodness. I don't even understand the mechanism of that. Just some irritation that it's enveloped inside, or just some
Yeah. I
gooey.
see these. I don't see these routinely, but we see them but they are an occasional visitor, which is intratendinous ganglions.
Yeah.
Yeah.
Where
And
do
this
you see
one,
them mostly on uh, you know, periodic loading, or are we full weight bearing, or where do you normally
I've
it?
seen them in all sorts of things. I saw one in a finger tendon
Okay.
in someone who pianist or something like that, or someone who did a lot of work with their hands. Uh, I saw them in. I've seen them in proximal biceps. I've seen them in some of the foot tendons, the peroneus brevis, things like that. So they're hard-working tendons, but
Yeah.
what tendon isn't hard-working?
Do you attribute the inflamed sheath, or the fluid in the sheath, to that irritability? Because we're long axis on it now, right?
Yeah, uh, I don't know. Is the short answer.
Wow,
Uh,
that is cool.
it's the tendon will be abnormal, but it doesn't necessarily. We've seen problems where in sort of wrist extensor tendon, where one of those has had a ganglion in it, where almost certainly what was happening is the ganglion was then causing a stenosis
Yeah, yeah,
as it shoved through the retinaculum, and
yeah.
that was causing an effusion in a patient. But in this case, yeah, I just don't know. I think it might be that the ganglion is leaking. It could be just the tendon's a bit swollen and it's friction somewhere, or it might be just the way the gods felt on that particular day.
Now, did this person come to see you for deep anterior elbow pain, or what was the what?
Yeah, yes, it will have been swelling, pain and swelling in the anterior elbow. You
Isn't
know,
that something?
query lump, query lipoma, something
Yeah.
like that. And then you go and you go, oh, that wasn't what I woke up this morning expecting to see. But it's that crazy thing, like, and I'm sure I've said this before, when people talk about rare cancers, and
Yes.
rare cancers are the most common cancer.
Okay.
And this is something I see certainly in my ultrasound practice, is that rare things are actually more common than the common things, or at least as common as the common things.
Yes.
There are a lot of rare things out there.
What about that?
And that's sort of my argument against the people who knock imaging and say you don't, common things are common. I say, well, they're not as common as rare things. Which is why people have such a mediocre success rate. Is
Exactly right.
because they treat the common, and they presume because it's common, it's going to be one of those common things. Well, really, I think that the analogy with cancer is the same. It's the uncommon, the rare stuff that is the most common stuff. If you think your first diagnosis in the hand or in the foot, I think there were some studies came out of Canada a few years ago, and I don't know, I didn't look in detail at the rigor of it, and it would have been from general practice. But ultrasound changed the diagnosis in 60% of cases in both studies, and about 43% of cases it changed management.
Yeah,
And
that's phenomenal.
yeah,
Yeah,
but and that will vary depending on the experience of the clinicians.
right.
If you're talking about specialty clinicians, but I get a lot of referrals from specialty clinicians, and and a lot of them very experienced, and we still find very much what we see doesn't fit in with their initial diagnosis, and which is why they send them for. They say, it's not. this is what I think it is, but they haven't got better with the what I expected. And and to say one of my one things I'm really pushing at the moment is trying to get people to look at for osteoarthritis in the shoulder.
Talk to me through that.
Well, I work in two different environments. One in radiology, where I probably see an unexpected finding of arthritis in the shoulder, glenohumeral joint arthritis, in probably less than 5% of patients coming with a typical cuff sort of pattern. You know, we see lots of occult frozen shoulders and a small number of occult in genuine primary glenohumeral joint arthritis in patients coming to, you know, not at the age of 70, but in their 40s and 50s and occasionally in their 30s.
Now tell me, John, you're making that judgment based on the appearance of the joint surface,
Yes.
and you're not seeing any type of hyaline cartilage, and you're seeing a lot of um, um, non-smooth cortex or a lot of osteophytes that surround the joint junction, or when you're saying that, what are you meaning?
Let me have a look. When I'm scanning the shoulder, it's probably better to show if I can find it. I might be able to see if I can find show you what I mean. Let's just look at video. May or may not come up. I don't know how good the filters are. Occult glenohumeral joints. Oh wait, yeah, this is probably the right thing. So we go here. So I'm just going to play you a couple of clips. So this is the anterior shoulder. Yeah. So if I grab here, this. No, that's not what to do, but right. Let's see. Sorry, a moment. Okay. So yes, so you're looking at bicipital groove.
Yes.
Ignore the quality of the image, and you will go into extension, and you can see that here the boundary with the articular surface is abnormal.
We're talking external rotation, seeing the subscapularis.
Yeah, seeing the subscapularis, but
Yes.
looking at the subscapularis clearly
Right.
being stretched over osteophyte.
Right.
Let's have a look. Where's the next one? Okay. Joint anterior. Right. I don't know why I'm getting the same. Sorry, I'm getting the same video up every time. Glenohumeral joint OA. This is the problem with coming and searching it and having used the video in various things. So let's have a look. Yeah, this is the inferior margin there.
Yes.
The glenohumeral joint. So this is looking in the armpit.
Yes.
And scanning up through, and you just see this clunky appearance here. And there actually, we do see it in the back of the joint, and that's where I certainly have looked for it in the past, and just the abnormal shape of the glenoid there.
The back of the joint, meaning posterior, and you're approaching it with the arm at the side.
Yes. Yeah. So that's there. But these findings in patients who have often been treated for years. And I remember one particular case that really brought it to the fore with me, where they'd been doing physiotherapy, dedicated, active, strong person for years, 5 years, they said, and it just made it worse all the time. But everyone just said rotator cuff. They'd had a scan, showed some tendinosis. They had looked at it, and yeah, there was some tendinosis, as you'd expect when the tendons are having to stretch over the over these deformed glenohumeral joint. And it's like, no, he's not going to get better with exercise. And there's a reason why his shoulder is stiff. But as I was saying, about less than 1 in 20, and I audit my radiology scans for that reason, to see what the numbers are like. So primary patients presenting to the GP, going for an ultrasound, it is not, that's a very unusual or relatively unusual thing. When you get to my role where I'm seeing patients who failed management, it goes up to somewhere between 1 in 5 and 1 in 10. So maybe between 1 in 5 and 1 in 10 shoulders have a significant alternative diagnosis that explains why they're not getting better when they get to my stage. They don't have, they either have everyone who comes, there's going to be a reason why they failed management. And sometimes that's rotator cuff tear where that's not expected in someone who's younger than it should be, or more often frozen shoulder that's being treated and they've come through relatively quickly, so they're still in that phase, or quite often frozen shoulder still giving pain a year or two on, which doesn't fit with the standard picture. But often I suspect their activities in combination with the frozen shoulder mean that the frozen shoulder carries on hurting because they're irritating the joint because of the poor biomechanics. But whatever it is, but of that group, anything up to 1 in 5, somewhere between 1 in 5 and 1 in 10 are occult glenohumeral joint OA.
What do you do?
Two things really. One of them is often explain to them what's going on, which is often a huge relief to them because they've been managed, they've been injected, they've had all sorts of things that just don't work. So, but they're always being beaten up, told to do exercises. I say, just stop the exercises and it will stop hurting. For a lot of them, when it's not severe, we inject them. When they say, some of them are they come for an injection, so I give them a glenohumeral joint injection, and they often do very well. But often I say, they're coming to me having battered away at their exercises. I say, before we go in and do an injection, just stop doing the exercises. Stop using your arm above shoulder height. Stop thinking that somehow you're going to push through that block in the end of range movement. Just come back and use it in its comfortable range. And a lot of them will just do very well. And you don't really want to go down the road of injecting these because that will just increase the rate at which that osteoarthritis will progress, particularly if they're in their 40s and you're going to do, they could do, if they work hard, try and work through it, or they're busy doing things and they don't manage the pain, what causes the pain, then they will end up getting injections often and whenever they ask for an injection, someone's going to give it to them. And then they're going to have 5 or 6 injections in the period of 2, 3, 4 years. And so they're going to reach their late 40s and we're going to be doing shoulder replacement on. And that's, shoulder replacements are very good. They're not good enough to justify doing them willy-nilly in an active person when they've got another 15 years of work ahead of them. So
do you see shoulder replacements compared to, let's say, hip replacements? Are you guys doing like 10% shoulder replacements? How big is shoulder arthroplasty over there?
I don't know because I think we manage them really well in primary care, certainly within the services that I work in, and so relatively few go that way. And so it's not. I don't think it's such a big thing for us, but they're certainly doing quite a few, and I don't see them. So they're not coming back into our services. So they seem to be a very good procedure. But we probably, I suspect our surgeons are doing more reverse geometry shoulder replacements. Than anything else.
Better sense, especially most of them have lost their, if not the viability from atrophy standpoint, they've torn it how long ago? So might as well have the deltoid do all the work.
Yeah, and they we do them relatively late, certainly in the NHS, and so that they tend to be in people with low demand. And yes, all the surgeons have their case where they've got the patient doing this, and it's great for their presentations. But the reality is that they're doing people who are just happy to be able to put a fork to their mouth maybe brush their hair, and that's a win. And for that, I think from what we see, the reverse geometry is a good operation, and they've done enough of them now that they're quite good at doing them as well. which is nice.
So in your general scan practice, it's about 5 to 10%, but in your geriatric practice, it could be up 20% for.
Well, they're two. No, it's in the practice where I'm seeing people. They're first, sometimes they're first referrals
Oh,
for
okay.
those. That's when you don't see very many. So they're not in the general population.
I've got you.
The reason these are considered rare is because they aren't very common. They're more common than I think than people give credit for, but they're still certainly not a common presentation. But if you come round to the population that are not doing well with therapy and have had their problems for a while, those are the ones where I think this is the issue. And often the rotator cuff looks pretty good indeed. It's in fact in the younger arthritic patients, seeing a rotator cuff, even in the older population, that's often the thing that makes me think, oh, am I going to find arthritis when I go around the corner? This patient actually has a pretty good looking rotator cuff. And I don't know whether whether that's just an association or there's actually a process going on there. But the tendinopathy that my colleagues sometimes call when they scan these guys is partly the artifact, because it's often taking a perverse course, and then more difficult shoulders. But yes, these are not the classic cuff tear. That complete cuff tear and sort of the and arthritis is quite a late stage older patient. And yes, you do see those.
Now you had said until you go around the corner. I'm assuming until you leave the interval view and you start looking at the posterior
Well,
posterior shoulder.
posterior, but you for a lot of arthritis, it's posterior inferior, and actually sometimes it's really you only see it with the inferior view, which is why now it's part of my standard exam. I always look into the axilla when I scan shoulder.
And you're looking for osteophytes. You're not looking for loss or thinning of the dark articular cartilage.
Uh, no, no, you don't. You're just not seeing enough of that for that. Even this is very very subtle arthritis in the shoulder.
Your point to where you're talking, that little white
Just
area.
here.
Yeah.
Just a little.
The dark area to the right of that,
Yeah.
it is that, yeah, that can't be articular.
No, the articular margin is all this bit to the left here.
Okay.
Yeah, or left on my screen.
Yeah.
This will be the articular margin, and that will be off towards the insertional zone.
Yeah.
Or just below the insertional zone in this case.
So your probe will at what point do you go long axis on the humerus and then aim it up toward the humeral head? Is that toward the end of your scan on the back?
Yeah, no, I do.
You've looked at labrum, you've looked at infraspinatus, you've checked out the suprascapular notch and all that kind of stuff. And it's at the end you then come back and you say, all right, do they abduct to 30 degrees and you come up to it, or do you just gently pull the elbow out and
I just asked them to put their hand on their head.
And then you come at it where? Okay, so just right underneath here.
Yep. I just line it up on the humerus and crack it on in there. Drop the depth down as far as 6 centimeters if necessary.
You're not measuring capsule. You're not doing that. You're just looking for big bony bulk.
No, both. Okay. I don't measure the capsule. I don't find that.
You just look at it and say that's big.
I just eyeball it and say, I think that's thickened or not thickened, and how I feel about it is evolving. But yes, that was why I started looking, because I wanted to have a look at the capsule and to make some sort of reliable thing with the frozen shoulders, and then I started picking up that actually sometimes the early OA is most evident at that point on ultrasound,
and it's evident in that you'll see the bony the osteophyte, or at least that little beluga whale hump.
Yeah, yeah, just a little change. It should be, if we go back, if I just go thickened capsule here. So thickened inferior, probably better one. I have to remember what I might have written on in my cases. So we should have loads of thickened inferior capsule. That's just that's probably a good one to go for. That's not a very good case for you, actually. I'll go to the next one. Let's try. Just gonna run through a sequence of them. Yeah. So here, this is not a great picture, but you see that margin there of the bone.
Yes.
And you just get a bit of lipping there.
Yep.
And a bit more. This I think is frozen shoulder. So that's not one. I say these are a bunch of frozen shoulders that I will be showing you. But let's see what. So there's thickened coracohumeral ligament, and there's the inferior margin there. This is yeah, just there. But it's that shape that I'm looking for. That these are not good cases for where I'm going. But there you see just that example, just starting. I wouldn't say that was abnormal. The capsule is abnormal, but that bump there isn't. But if that becomes any more prominent than that, because it should be a nice smooth down, it's pretty reliable in almost everyone that doesn't have age arthritis type changes, for that to be a nice smooth line. See if I can find if that one again is. Let's see if it's let me pick up. Yeah, that I think is acceptable, but it's still a little bit bumpy, and anything more than that is that's very normal shape of the bone. But if it's not like that, then you're asking the question: is this arthritis? And obviously they're the ones I showed you where it's OA.
I want to be respectful of your time, John, because I want to keep tapping into your brain, and so you call it quits when you need to.
Yeah. Well, I'll go. What time? Oh, we're gone past half. Yeah. Well, we'll get. I'll just see if there's. Oh, we've already seen that one. Yeah. Glenohumeral joint through subscapularis. Let's just have a look at this one to finish with then. Yeah. So this is glenohumeral, the anterior, and I always grew up not really taking whatever the bone looked like underneath subscapularis. I always just ignored it. And when I thought it was OA, it didn't show up on the X-ray, and so I would not call it. I would say, it doesn't show us. Now I am much more aggressive in the sense that if I don't see a curve that resembles a round head, then I'm very much switched on. I will flag it, and particularly if you see this sort of lipping as well on the edge under there, that's anything that's forcing subscapularis to go around a bit of a corner, get to the target, and that's abnormal.
When you say it didn't show up on X-ray or it didn't reliably show up on X-ray, I'm assuming you're talking it did not have the brightness that normally reflects the sclerosing of it, or how did it not show up?
When whoever's read the X-ray, and when you look at the X-ray, you can't see any arthritic change there. So you're not seeing OA on X-ray. I always took X-ray as being the gold standard. Now I'm of the opinion that ultrasound has at least as is specific when you see it. Not necessarily what you don't see reliably on ultrasound is loss of cartilage.
Yes.
So they can have cartilage wear, and though when it's severe, you can see it. You look at the back of the joint and you go, that the bones are not, the glenoid is not normally that closely aligned to it. But that's in a fairly severe case of arthritis. You go, oh yes, I can definitely see a loss of cartilage there. But I think X-ray will see that before you see it on ultrasound when it's done, when they're lucky enough to get the right slice. But in terms of picking up arthritis, glenohumeral joint arthritis, ultrasound certainly appears to be much higher sensitivity than a plain film for this. And I think these are one of the cases you can argue backwards and forwards when we see subtle tears and tendinosis in the rotator cuff, whether doing the scan does the patient any significant good as opposed to just the placebo effect. But I think spotting glenohumeral joint arthritis is life-changing for them potentially, because this problem shoulder that won't go away endlessly, certainly in the UK where people don't operate. And even if they do operate, it's, what are they going to do if they unexpectedly find OA on a rotator cuff and subacromial decompression or whatever? They're not going to do any good when they go in there. Whereas you can change things around if you recognize it and say, actually, you've got an old shoulder. You're not going to be throwing ball. We're not going to get you back to that, short of a joint replacement. So let's change the way you're managing it. And I think that improves patients' lives.
No question about it. John, as always, thank you for your time. I know I threw out brachial plexus because I had a scan today of that, and of what relevance is the thickened nerve roots that are going through what looks like to be. I tell you what, I just don't know the utility of it. I think more than anything, as a guide for anesthesiologists and pain, to deliver the product where it needs to be.
Yep.
I can see the value in that, but I just don't think we have we just don't have standards that are good enough to have us go, that looks like it's.
I don't think there's a role at all for musculoskeletal scanning of the brachial plexus. I've never seen anything useful when I've looked at it. If I saw a mass in the area, maybe, but that's a 1 in a million. That's a unicorn, even by my standards.
How do you quantify tightness of pec minor, or how do you quantify stuff that structurally, the arm is dynamic? How do you where are you going to hold the arm to have a standard tightness? And it's just one of those things you just go, yeah, I don't see anything, neoplastic in the area. Do a nerve conduction or do something that evaluates, where this is along the way.
I'm not sure what pathology you could possibly see on ultrasound. Now, one day someone will find something and they'll have some measure, but in my hands and in anything I'm aware of, people look for use ultrasound to assess for thoracic outlet syndrome, and there may be some merit in there, but I can't think, unless you're looking at a specific vascular thing, and there are vascular tests for it, but unless you're doing those routinely and seeing patients where it's appropriate, I can't see that anyone practicing like I am, or I suspect like you are, is going to see anything useful.
Right.
And I certainly, and everything I've read has made me think that if I did happen to notice something relevant, it would be by more luck than any sort of judgment. So yes, I'd push back on those. I would say, we're not going to see anything useful there. If you want to send someone to the vascular team and speak to someone who specializes in vascular, because you think that there's a vascular element to the thoracic outlet, then maybe that has a role. But if you think it's a structural thing around an extra rib or some fascia there, you you'd have to do a lot of it, I think, and have a very specific patient group before you would develop the skills necessary to get to see anything useful or
Good.
with any sort of reliability.
Good. I'm not going to spend any more time on it then, John.
No, did I? I shouldn't have just said that. I say,
No, no.
Greg, don't
I'm,
waste your time.
I'm just there's so many other things that we can structurally take a look at that
Exactly.
so many variables, so many tension points, so many things that I think anybody who shows me a thoracic outlet syndrome that looks like a nerve is doing some stuff, my mind is just going, yeah, and what contortion did you have to put your wife in order to get that picture,
Yeah,
of the nerve going. Anyway, John, thank you for your time. Tell your family thanks, and we'll connect
that's
again.
right.
All right, take care.
Right. Great to see you.
Bye.
Bye bye.